So we're going to get started with the panel part. Obviously, you've heard some of our panel speak already. Should we have Sean Sachdev from Radiation Oncology, Deric Park from Medical Oncology, Vinai Gondi from Radiation Oncology. We have Misty, who's one of our nurse practitioners who works with our patients on the inpatient side of things, but she has a unique background in being specialized in pain management. So we're going to have some questions about pain and pain management as well. And then myself, and I'm going to answer all your questions on mobile spine and sacrum for surgical side of things, but also I'm going to wear the hat of skull base as well if there are questions that come up, because Jim had to go to another thing as well.
Okay, thanks, Jean-Paul. You all can hear me? So my name is Ed Lassa. I'm also a physician, but I'm a skull base chordoma survivor, 12 years in. And in large part, I utterly convinced because of the efforts of the Chordoma Foundation, the access I've had to expert care and treatment over the years. So I'm very much indebted to the foundation, to the organization, to the efforts of people like you see seated to my right. You've all heard the adage, I'm sure, those people who can't do, they teach. And the people who can't teach, they think they can lead. And so they jump into administration or politics. There are lots of exceptions to that rule, and the panel we have here represent people who not only do, but they also teach and they also lead, and they've been important, incredibly important to the success of the Chordoma Foundation. So the way this is going to work is I have a whole bunch of questions, and it's frankly going to be impossible to get through them all in the next hour and a half. But we'll take a good shot at it and try and cover most of the issues and topics that you guys have brought forward. So we'll do, for the first hour, I'll try to cover most of the topics that I have in front of me here, and then in the last half hour, we'll have an open mic, and you can come forward from the floor and ask any questions that you feel haven't been addressed. It's important to remind you that we still have a whole bunch of material coming this afternoon. So if you feel like there's big gaps that haven't yet been covered, it's almost certain that the material will be covered this afternoon. For those of you that have given us questions on these cards, and you've given us your email address, if there is material that we find on here that we do not cover, we will try to be sure to respond to you by email after the session is done, after the conference is done. One more thing, just to remind you, out on the table out there is the expert recommendations for recurrence booklet that has a wealth of information for the many of us who deal with chordoma recurrence and the various strategies that we have in place to try to deal with that when it happens. So, without further ado, let's start off with a surgical question for Dr. Wolinsky. Have there been improvements in surgical techniques to remove tumors that involve carotid or vertebral arteries?
So there have been advances that for removing tumors that involve, you said the carotid arteries?
Carotid and vertebral, yeah.
So carotid and vertebral arteries. So as far as vertebral arteries go, we have two of them, one on each side, and they connect together on everybody. When we first started working with tumors in the cervical spine that involved the vertebral arteries, we would test people and do something called a modified WADA test, where we'd occlude that vessel to see whether or not a patient could tolerate having that vessel occluded. So you'd be awake and we'd occlude it and make sure that your brain was working fine. And then if it wasn't tolerating that, we wouldn't sacrifice that vessel. What we found, though, over time is that actually everybody tolerates having one of those vessels sacrificed if you need to. My philosophy about it, though, is that I like to spare that vessel as much as possible, because I can't guarantee that with a negative margin resection, a negative en bloc resection, that there's no chance of that tumor not coming back. And so I always want to have something in my back pocket as an option. So if that artery is sacrificed, we might not have options for them down the line as far as radiation or more surgery, because we might be relying on that vessel. But we can sacrifice that vessel if need be to get the tumor out. As far as the carotids are concerned, those are not as easily sacrificed, but they are easier to bypass if they need to be bypassed beforehand. So that's actually fairly old technology, but it's one that people have gotten better and better at. So we can bypass those vessels if need be for taking out tumors.
Thank you. Next question, radiation question. Perhaps Dr. Gondi and Dr. Sachdev can both speak to this. Side effects from radiation. Patients ask about things like osteoporosis, arthritis, diabetes, brain damage as side effects. Are these possible long-term side effects of high-dose radiation? These things that people are worried about.
So, the challenge with radiotherapy, so with surgery, when a tumor is taken out, chordoma tumor, and a patient awakes from that surgery, if they have any unfortunate consequences of that surgery, they wake up with those consequences and they have a time of rehab from those consequences. With radiotherapy, the effects, most patients who go through radiotherapy actually do just fine for the most part. It's just that those side effects of radiotherapy can be long-term, can be many years down the road. And so, yes, there are long-term consequences, some of which you mentioned can develop. Certainly in the clivus, the skull base, we talked about a lot of those important organs at risk in that area. Whenever I develop a treatment plan for a patient with a chordoma, I have kind of priorities in my mind. I have objectives. Certainly controlling that tumor over the long term is a high objective. The brainstem is a high objective. I've been fortunate after treating several dozen chordoma patients that none of my patients yet, to my knowledge, have had any injury to their brainstem, and that's really important. But other objectives are the vision nerves above and the ability to stay below what those tissues can tolerate. And then the temporal lobes, which are right beside the carotids that were mentioned. In the spine, we typically don't see radiotherapy inducing osteoporosis, but it can weaken bones, especially those who have some degree of osteopenia at baseline. And this is where we rely on our surgeons to ensure that we maintain mechanical stability of that area, both before we do treatment as well as down the road. Some things in radiotherapy we cannot control, and a classic case of that is the pituitary gland. The pituitary gland is located essentially within what's called the sella. It's right in front of the clivus. It's often something we have to treat to full dose if we want to treat the entirety of that target and prolong tumor control. And it is not uncommon that patients we treat several years down the road have some pituitary insufficiency. So it becomes important that all patients whom I treat, I immediately establish with a neuroendocrinologist from the get-go for continued surveillance. So there's some things we can help with and prevent, and we use our technology to do that as much as possible. And some things that we can't, we have to ensure that those are surveyed down the road. But it's also important that as radiation oncologists, we continue to follow our patients down the road because we see some of these issues develop years down the road. Sean?
That was very well said. I'm just going to add a few points. Very sophisticated crowd here. You probably all know this, but radiosurgery and radiotherapy, any kind of modern radiation is very focally delivered. So it's kind of like surgery. It does not travel through the bloodstream. It's not affecting any other part of the body. So any effects of treatment, good or bad, will all happen where we're quote unquote pointing the beam. And especially in recurrent cases, we have to consider the effects of prior doses delivered to the area. And what's also important is that you may read literature about the effects and toxicities of radiotherapy, but they all of those may not be perfectly applicable in your case. When we design a radiation treatment plan, we three-dimensionally model exactly where the dose is going. So it's very important to have a candid conversation with a radiation oncologist who will guide you through, what are the likelihood of potential toxicities in your case. So it's very, very much specifically and individually driven by your anatomy, where the lesion's located, the proximity to critical structures. In the case of recurrent lesions, what has been treated before. So, yeah.
Thank you. Question for you, Dr. Park. Question is, can chordoma come back at any time, and what are the best ways to monitor for recurrence or spread of the tumor?
Yes, it can come back anytime. It's unpredictable, and the way chordomas grow is not always gradual for reasons that we don't quite understand. It could stay silent for quite some time after treatment. It could grow slowly, or it could grow rapidly. We call it saltatory growth. We don't understand why that is. There must be some sort of switch that turns on these cells on. It could also metastasize, as you know. So it's important to monitor without a question, and it's best to speak with an expert who understands the disease. And the frequency monitoring, that all depends where your tumor is, how big it is, when was the last treatment. So it should be customized for each particular case.
Deric, I'm going to just ask a question myself to put you on the spot, because this is a question that my patients ask all the time, and I can give you my answer about what I think about it. But so every one of us that treats a lot of chordomas see very unique things every once in a while that aren't the common things, right? And it really freaks out other patients that have chordomas. The question is, okay, if I have a sacral chordoma, should I get the rest of my spine scanned? And I say, well, unfortunately, we do know patients that have that, but it's exceptionally rare, even though you have an exceptionally rare problem in the first place. So if you're 1 in a million and you're like, well, that's another 1 in a million that you have more than one, who knows what the right answer is on that, right? Because obviously you had the scan in the first place. The other question that comes up is how often you should have them scanned. And looking at the site of where the tumor was resected, I always recommend getting MRI scans every 6 months for the first 5 years, and then at 5 years, we can talk about whether or not we want to extend that to an annual exam. And I would say that the majority of my patients say, well, I hate having that MRI scan because it makes me very anxious, and I have to tell them that it makes, even though I don't really say this out loud, it makes me very anxious because it's a bigger test of me. But once they get it 5 years, they're like, ah, you know, I still want to get it every 6 months because it just gives me that sense of well-being. And I completely agree with that and understand, because we never know when these are going to come back. And then the other question comes up, what about areas of metastasize? Should I get my chest scanned regularly or x-rays regularly, or what's the answer to that? And then if I have a tumor, should my kids get scanned? Even though I only know of 2 patients worldwide that have familial chordoma, but what do you think the answers are to these?
So far as scanning, I agree with what you said, every 6 months is reasonable, but I typically suggest that every other scan, we scan the entire axis. So if you had a sacral tumor, we would do every 6 months, or if it's every year, but every other scan, I will take a look across the board. You know, it's controversial because as a neuro-oncologist, a lot of patients that I see that come with me for a lesion in the brain, and it was incidentally found. For instance, they have headaches unrelated, we find a mass. What do we do about that? And some of these patients get surgery and they have more complications. So sometimes knowing too much is not always a good thing, but in a patient with chordoma, where we know that it could spread, I would recommend being a little more vigilant.
Thank you, Deric. Back to you, Dr. Wolinsky. For mobile Spain and especially sacral patients, in recent years, the treatment protocol for a new diagnosis has shifted from surgery followed by radiation to a combination of pre and post-op radiation, sometimes no radiation at all. Why is this, and how do doctors determine which approach they recommend? That's a big topic. Okay,
so I'll talk a little bit, let me talk about first preoperative and postoperative radiation therapy. So there has been a school of thought, the idea of whether or not preoperative radiation would be helpful for patients with chordoma, and that probably stems from our experience with sarcomas, where we give preoperative radiation, especially to extremity sarcomas, prior to surgery, with the idea of trying to minimize the dose of radiation postoperatively that we'd have to give. Because if you, and this is my basic understanding of radiation oncology, but if you have a target to give the radiation to, you can give less radiation to it than if you don't have a defined target where you'd have to give more postoperatively. And so that's where that school of thought starts. Now, Fran Horncheck and Tom DeLay, when Fran was at MGH, they came up with the idea of doing this for preoperatively with protons. Now, I have a lot of reservation about doing that, and the reason why they came up with doing that was because they were seeing these recurrences with their resections, and they wanted to try to minimize the amount of recurrences in that area. And I think everybody has their different experiences with recurrences and how they monitor them. In my experience, we have, I mean, obviously we have recurrences, unfortunately, but it has not been so dramatically high that it has pushed me to the idea of preoperative radiation. The downside of preoperative radiation is that it makes the surgery that much more difficult. The nerve roots are not as resistant to manipulation after radiation. So if you have somebody who you're trying to spare certain nerves and they've been radiated ahead of time, they might not be able to tolerate that as well. They can tolerate one or the other, but not both in a combination. The other problem, especially with the sacral tumors, is if you have preoperative radiation, the wound healing can be a problem. And so I quote people that the risk of a wound infection without radiation therapy for a sacral tumor is about 40%. Doesn't mean that everybody needs an operation for that wound infection, but it can be that high. And if you don't study your own patients, you don't really believe that that's as high as it is, but it is. If you add radiation to that, it's probably at about 100%. And whether or not these wounds can ever heal, it's questionable. And so it's a balance between potentially curing that patient and having them have a lifelong problem with the wound versus the risks of not. And so I having worked with Norbert Liebsch for a long time, remotely, because he was in Boston, I was in Baltimore, we would save radiation for those patients that would recur rather than having it as a knee-jerk reaction for postoperative or preoperative radiation. Does that answer your questions?
Yeah. Awesome, thank you. Yeah, go ahead.
So as Dr. Wolinsky mentioned, this is a little bit of an area of controversy, and I admit I've done both in my practice. And my biases are, so the principle of preoperative radiotherapy, whether it's done with protons or otherwise, is the idea I mentioned earlier that the way radiotherapy works is it stunts tumor. So when we stunt a tumor cell and it's resected thereafter, and if there happens to be any seeding or anything in that operative bed, our bias is then that tumor has already had DNA damage deposited, and therefore it won't grow after that surgery. However, it does become important to recognize that the radiotherapy, if it's done preoperative, can augment, as Dr. Wolinsky mentioned, this issue of wounds, and I think that's super critical. So my bias in my practice that I've come to appreciate over several years is it's a discussion. No two tumors are made alike. Everybody has a different own presentation, and it's a discussion between the surgeon, the spine surgeon, and the radiation oncologist. If I feel comfortable that a talented surgeon like Dr. Wolinsky can get around the tumor, not an intralesional resection, do a very good en bloc resection, and remove the tumor, then to be honest with you, at that point, I don't see a role for radiotherapy. I spoke a little bit about this issue of microskip metastases, but after that situation, we're just treating air, essentially, right? We're treating a space. We're not necessarily treating a particular target. And so the reason radiation oncologists feel very uncomfortable doing radiotherapy after a big surgery, spinal or sacral, is because we can end up treating more than we really wanted to. And that too can have side effects as well. So if I feel comfortable that a surgeon will get around it and get it out and we'll get an en bloc resection, then I don't even do radiotherapy and I just watch. If there are situations where an en bloc resection is not safe or feasible, and Dr. Wolinsky mentioned a couple cases in his experience, I think that discussion has to be had between the surgeon and radiation oncologist is how do we handle the situation? I have treated sacral chordomas after a surgery, and I know that my field is much larger than it was going in, but I am not in a position, I don't ever want to compromise someone's wound going into a surgery. So that's an important consideration. So I think it's just having that multidisciplinary discussion and consideration, recognizing that every tumor is very different.
Sure. Thanks, Dr. Gondi. So Misty, I'm going to throw this question to you first, and then others can weigh in, because it kind of cuts across all disciplines, I think, and this comes up frequently. The issue of pain, the question as it's put here is, for skull-based patients, is it common to have more pain headaches after surgery than before? If so, what causes it? How long does it usually last? That's relevant not just to skull-based patients, it's post-surgical patients in general. I think it's an issue that relates to the pain service quite frequently. How would you answer or address those concerns from a patient?
As far as headaches go after skull-based surgery?
Pardon me? Yeah, so for the skull, this was a question posed by a skull-based patient, evidently someone who had, more pain, more headaches post-operatively than they went into surgery with, and, why is that? And if it's, if there's a reason, how long can they expect it to last, and how can they manage it, sort of thing?
Want me to answer the why, and you answer the how?
Yes.
Okay.
There you
So the why, we don't really understand why people get postoperative pain from different things. I think a lot of it's from scar and scar tissue. The dura, which is the sac that surrounds our brain and also our spinal cord, in our head has a lot of sensitivity to it. There's a lot of nerves that go to it, and that's probably where a lot of that pain arrives from for the headaches. Okay, there's other reasons for headaches as well, just because, what I tell people is that we're really not designed for surgery. If we were designed for surgery, we'd have zippers everywhere, right? And so, we're doing something that's really unnatural for your body. And so we're asking a lot of your body to heal. And unfortunately, the way things regrow and heal together can cause pain. And how we manage that later, as long as there's not something that's a side effect from what we need to fix, meaning like if it's a spine patient or a sacral patient, a rod or a screw that's broken or something that's not healed, that's one thing. But if it's something that looks like everything's healed as best it should, then the question is, how do we treat that patient's pain to make them as functional as possibly can be?
So I think the how we treat it, it really depends on what the cause is. But there are medications that we can use to treat it. And sometimes those don't always work for headaches. So just helping people to cope with that, I think is very important. Medications don't always treat everything. So if it's caused by a leak or of some sort, we can always use a medication that has maybe caffeine in it to sort of help with that headache. But I think headaches are just tricky. It all depends on what the cause of it is as to how we treat it. Sometimes they do turn into chronic headaches, and then those are, again, not always easy to treat. I don't think I can give you a list of all the specific medicines that we can use for headaches, but I think an important part of that is just really learning how to cope with headache and do things that may be beneficial. Meditation, massage for the chronic headache.
Thank you, Misty. And related to that, there's another question around this chronic pain that many of us live with in the months and years following chordoma surgery, radiation, and treatment. In your opinion, is that sort of pain best addressed by patients' family doctors or by a pain specialist? Like, who's best, in your opinion, suited to help these patients navigate that difficult path?
I think, there's not enough pain specialists and pain physicians to go around. So, and it really depends on your area of location. So in an urban area, it's easier to find a pain specialist. But I think general practitioners are good at managing that. A lot of the general practitioners do reach out and collaborate with pain specialists. So I think it really depends on your location. So general practitioners are suitable and are trained, and some go through extra training to do pain management. So it really depends on your location. But I think either a pain specialist or a general practitioner, or a general practitioner in collaboration with the pain specialist.
Sure, thank you.
Just going to add one more thing. So during radiotherapy, this becomes an issue. We see it often. So my practice is during radiotherapy, if we're not able to manage that pain effectively, for a skull-based tumor, I actually get a neurologist involved because there are several headache medications that can be used that I've found to be useful in our patients.
I'm going to add one other thing, and that is that I think it's very important also for patients to connect with their family doctors because they are closer to them, especially, Chordoma is 1 in a million patients, so it's not like everybody's from Chicago, where when I was in Baltimore, definitely they weren't all from Baltimore. And so patients with chordoma travel, and just getting your medication in a timely manner, I mean, you're going to be better served closer to home. The other thing you have to be a little bit careful with pain management physicians are that they're not necessarily great for long-term treatment for pain, because many of them are doing injections rather than doing regular maintenance medications and things like that. So you have to make sure that you have a relationship with that person. The other group that's very helpful for pain that has, I think, probably not the best title in the hospital is palliative pain medicine service. And the reason why I think that's not the best title is people associate that with end-of-life care, which is, it's some of their care, but there are a lot of us that have chronic pain throughout life that need palliative care medicine to help, and patients that have oncological problems are probably best suited with those physicians than others because they can understand them a little bit better. So it doesn't necessarily mean, palliative care medicine doesn't mean end of life, it means palliation of your pain at this time.
Yeah, fairly or not, though, in our business, this is what it's come to mean. To palliate means, you know, to ease pain, obviously, but it's become associated very much with end of life.
I want to just make a comment. Just make it, there's a very sharp distinction between palliative care and hospice care. They are not the same thing. Some of my patients, when I speak to palliation, they assume I'm talking about hospice. Hospice is end of life. We make you as comfortable as possible. Palliation can begin with diagnosis and to follow you along. So when you hear the term palliation, it does not equate to hospice.
Thanks, Deric. Maybe I can pitch this next question to you. It's a general question. I am experiencing double vision and migraines. Who should I go see? Go directly to the neurologist?
So this is a patient with known chordoma or without?
I forgot to tell you, she's a 26-year survivor. It's Annie.
So
With
this is some
chordoma.
long-term survivor who is now having double vision and migraines.
So migraine is a very nebulous term. Migraine is a very So the question is, if you're having a headache, does that mean chordoma has returned? Is that the question?
We're very concerned because a lot of the doctors we've talked to, they don't know anything about chordoma.
Yeah. So that's often a big problem.
We haven't seen a specialist. The first one we saw was when she was 9 or 10, and that was Dr. Leach. And we haven't been back to him. Well, she had it in 1993, but we've gotten MRIs, but we've run into a lot of problems, is not so much the doctors, is where do we go about, this is what's worrying her, is she's got double vision and migraines. And the insurance is what we come up against. They won't let us go back to Dr. Leach.
So migraine is a very distinct entity. Often when patients experience headache, they call it migraine, but migraine is a very specific disease or condition. Now, that could mean a lot of things. Why are you having a headache? And they addressed that earlier. But double vision is more distinct. If you're experiencing double vision, there absolutely something is going on. And also double vision, are you seeing double at primary gaze? Do you see double when you're looking up, looking side, which way? So that absolutely needs to be investigated. Yeah, so that means there may be something wrong with the cranial nerve, something may be pushed or being pinched. That absolutely needs to be investigated without a question.
So
That would be concerning.
Yeah, who do I start with?
So let me interject. So I struggle with the same thing. I have patients who come from far away, like Dr. Leach. Dr. Leach is phenomenal and a tremendous expert in our field. And then they. Oh well, I'm happy to see you. Yeah, but I mean it's a situation where so if my patient that I've treated years ago is having any new issues, to the MRI, even if I can't see them by insurance, I want them to send their images to me and be able to look at those images. So I think it's very clear that it's very important that even if the insurance is becoming an issue, those of us who do have coronary referral patterns for chordoma, that we want to hear about what's going on when something is happening. It's something we're very passionate about. In terms of causes, I would say yes, we should double check for the tumor, but it is possible this could be a post-radiation thing as well. It's not uncommon to see neuritis develop down the road, even several decades later. So worth an evaluation and to look into further.
Thank you, Dr. Gondi. Thank you for the question. I'm going to spin this next question from the surgical angle first, Dr. Wolinsky. Are there any situations where systemic therapy or a clinical trial would be considered the first line of treatment for chordoma?
So I think that, this is a great question because, and this is what Roger was getting at with his lecture, is can we set up a clinical trial where we do what we call neoadjuvant or preoperative chemotherapy followed by surgery? And I think it's a great possibility. And the reason why I think it's a great possibility is that, in general, chordomas are slow-growing tumors, depending on where they are. Now, how you set up this trial is a little bit complicated, right? Because anybody who's diagnosed with the tumor is exceptionally anxious the moment they get that diagnosis. The moment they hear from the radiologist or whoever just called them up like, hey, you got to come back to go to the ER because we looked at your MRI scan that you had for back pain and you got this massive tumor, so come on in. And you're like, what? And so it's the first time you've heard about it. And most people's gut reaction is, get this thing out of me as fast as I can. I don't care about a biopsy, even in that. But that's, we know the pathway we're going to go. Now, if you have a tumor that's in a location that, if it were to grow a little bit, doesn't change your surgical options, doesn't change the sacrifice that you might have to go through, then maybe trying a clinical trial with a chemotherapy preoperatively is worthwhile. And then going with the standard of care of trying to get an unblocked resection after that. I wouldn't leave a huge amount of time through that, but I think it's something that is a possibility as an option to think about, and these are the things that we want to set up.
Let me just add to that really quickly. I mentioned it briefly at the end of my talk, and some of it is mechanics, right? It's such a rare tumor. It's spread throughout the world. And while we create chordoma centers of excellence, not necessarily all chordomas come to the Chordoma Center of Excellence up front. What we have is a unique opportunity in that a good significant proportion of chordomas are now being managed at proton centers across the country. It's almost enriching patients to come to those centers. And when that happens, like I mentioned, and we put it under an umbrella of a large multi-institution trial, we really have an opportunity right there. The mechanics are there to run a very interesting trial that will accrue very quickly, meaning within a couple of years. So that's what we're looking at right now, and especially as it relates to radiation sensitization and other options.
So this whole idea of neoadjuvant trial, we actually ran a trial. We did this back in 2010. Along with Larry Baker, who's a renowned sarcoma expert in Michigan, and my colleagues at the Mass General at Harvard. Unfortunately, the combination trial was too toxic, it stopped. But there's a lot of precedence for this. In fact, Larry Baker ran studies looking at another bone tumor, osteogenic sarcoma, exactly doing that. So, but again, to do a trial like that, it has to be mobilized. We have to organize. It cannot be done at one center. It's such a rare tumor. And I think that's why it's so important, not just the foundation, but also for you as patients to get involved and really ask these questions. And that'll drive this sort of study and research.
Let's just stay with you for a minute, Dr. Park. Speaking of clinical trials, how do you recommend patients learn about clinical trials? Which is the best for them? Who should they speak to if they're interested in a trial?
The best resource is obviously your physician, who is a chordoma expert. And if you have particular questions about trials that are available, the best person is probably Shannon Foundation. She knows everything. And she could plug you in with whoever be an expert. There's also a website, clinicaltrial.gov, that has all the trials. So it may not be chordoma specific, but often there are trials that will include chordomas. It could be under sarcoma, it could be under bone tumors. If you search it, it's available.
Thank you. There's a question from the floor. I did not get on a human trial last year because I was told my clavicle chordoma was too small. Why does a patient have to wait for their tumor to grow to get on a human trial? It seems like it would be better to start treating it sooner than later while it is still small.
This is a very frustrating point for a lot of us, but you have to understand that the clinical trial is intended to ask a question, very specific question. Does this particular agent work? Now, if your tumor is stable, we can't answer that question because we may just give you salt water to make it stable. So I know that I recognize it's frustrating, but again, the trial is intended to ask, when the tumor is growing, is this agent effective? So if you're stable, just recently received certain drugs, unfortunately, you will not be eligible.
Right, thank you. And then just one final point on the clinical trial set of questions. When will more clinical trials for chordoma be available in countries outside the US? There are some open in Europe and Australia, for example, but still very few.
So there are trials that are available in Europe that are not available here. I'm going to talk more about that later this afternoon, trials that are coming up. We often combine radiation with an experimental agent because we think it may be more effective, but it doesn't help for patients that have already exhausted radiation. But there's hopefully a few trials are coming up, and I will discuss that later.
Yeah, okay, thank you. Dr. Sachdev, a number of collaborative patients experience growth hormone deficiency following radiation. Is taking human growth hormone the only option for treatment? How do the experts feel about human growth hormone and chordoma and its safety?
As Dr. Gondi pointed out earlier, oftentimes the skull base are very close to the body's central organ that controls a lot of sort of the hormone function systemically, and that's the pituitary gland. And basically, if you're being treated around the pituitary gland or if that gland is getting a lot of radiation, that's something that a radiation oncologist will discuss with you. And typically what one would do is we would get a baseline set of functional labs to establish what your function is prior to treatment and then monitor that function closely as you sort of move forward with regular follow-ups. And growth hormone is just one of the other, many hormones that can be disrupted by treatment around that area. So typically that kind of close clinical surveillance is done with the help of an endocrinologist and again in close follow-up with your radiation oncologist and your other chordoma experts.
I'll just add to that important point. Growth hormone deficiency is challenging because it's not clear what the sequelae are for a patient when they have growth hormone deficiency. It's obviously a big deal for little children who are developing, but for adults, and it's partly a challenge because growth hormone replacement therapy, especially in developing countries, is super expensive and sometimes not covered by insurance companies. So what the thing to know is that what we do know is, to my knowledge, is growth hormone deficiency can slightly increase risk of heart disease and diabetes down the road for patients. If it has no other effects on the hormonal axis, then yes, an argument can be made, should we just watch this, or do we, if it's covered by insurance, do we give growth hormone? If the question was, does growth hormone have any adverse effects as it relates to chordoma recurrence, to my knowledge, that's not the case, and it's fairly safe to use growth hormone replacement therapy.
Sure, thank you. A few questions around this issue of metastasis. So besides the spine and the skull, what areas can chordoma travel to that are outside of these? How common is it for clavicle chordoma to spread down the spine and even to the sacrum? Can it go everywhere? What kind of scans should be done to check for these spots, etc.? I'll start with you, Dr. Wolinsky.
So if you follow enough patients, you're going to find metastasis in places that you can't even imagine they would have. So I've seen metastasis in the lung, I've seen metastasis in the abdomen, I've seen it into the liver, I've seen it into the heart. So it can go in all sorts of different places. Now, the big question kind of comes back to, I think was the first question is, what should you do with scanning and trying to surveillance for these things? I don't know the answer to that. I think it can drive patients completely crazy, figuring out what should be scanned and what shouldn't be scanned. My personal feeling is that it's very rare to see a metastasis without a local recurrence. And so if you've had a local recurrence, that's when you want to be even more diligent about scanning. Things that are coming down the line, though, are looking for circulating DNA in the blood to find out if you have recurrences. And so we have been, when I was in Baltimore and also here, we collect tumors in the operating room when we resect these, but we also collect blood from patients at that time. and then we'll collect blood later if they're in the trial for this. And we have been able to see circulating DNA in patients preoperatively that disappears postoperatively. And we think there's a trend to seeing it in patients that have recurrence, but we don't know that yet. So there's possibility that one day there will be a blood test for you to make sure that things aren't coming back, which would be way better than just imaging all the time. Doesn't get rid of the stress, but way better than imaging all the time.
So we actually looked at this in a systematic pattern. We ran the brachyury, the vaccine study. And because of the way the study was designed, we monitored patients on a regular basis, including a CT scan of the whole body because it developed metastases. We had to address that. And our experience is that it could show up even without local recurrence. We could see it in, interesting, like you said, we saw it in heart, which is very, very odd. Often under the skin, which we biopsied and found that it's chordomas. But getting a CT scan is an ordeal. Getting spinal MR, but I would agree. We don't have sufficient data to really give a solid recommendation. But it's not a common occurrence. We do see metastases more with sacral tumors and Clive. I think that was a question, and that's probably just virtue of the size.
Great, thank you. Related to that, and specifically regarding metastatic chordoma on the lungs, which we're seeing more and more, what criteria or what size, what number would prompt you to initiate treatment as opposed to waiting and watching?
So I'll give you my surgical opinion on that, because patients that have a metastasis in different places or even a local recurrence, the question is, should you remove that or should you go on for some other treatment? I'm going to kick this back to sort of Roger's talk a little bit about neoadjuvant chemotherapy. And my feeling about this is if that local recurrence or metastasis is not neurologically threatening the person or physiologically threatening that person, then I would be in the favor of getting somebody on a clinical trial or an experimental therapy with chemotherapy first and watching that lesion to see if it responds. Because yeah, we can operate, we can take that out, but if it's not actually harming you, what's the benefit of potentially putting you through the risk of surgery and just cutting and cutting and cutting? Now, when I was a medical student resident at Baylor under Dr. DeBakey, there were these, sayings, well, a chance to cut's a chance to cure, but I don't think that's the case in this situation. I think what you're doing is just making yourself feel better as a surgeon that you've taken that tumor out, but systemically is what you want to treat that patient for that. And so I would reserve it in that direction. I asked Deric his opinion about it.
I would agree. When I mentioned the previous question, we would monitor the metastases, and often for reasons that we just don't understand. Why would a tumor travel somewhere and plant and just sit there and not do anything? And not only that, when we see patients with multiple mets, they exhibit very different growth kinetics. One may grow, one may not. If it's not actively growing, we'll just watch it. I agree, I would try to enroll in a clinical trial to address that. There's often saying in our profession, are we treating the patient or treating ourselves? Because often we feel better if we think we intervene, but it's not always the best thing. I think at times just a tincture of time is a good thing and observe.
One more thing is that we see this with other metastatic cancers, but suspect it applies for chordomas, is that each metastasis that we see doesn't necessarily biologically behave like the other one. So you can apply a drug therapy and see response in some, but another lesion may grow. And this is sometimes where I actually use radiosurgery to focally treat areas of metastases or surgery that are growing on a drug therapy to permit continued drug therapy in that situation.
I would just add to that. I was actually about to make that very, very comment. When you're dealing with metastatic disease, that's a whole different, clinical entity generally. Now we're dealing with something that can travel around the bloodstream. And I would agree with everything that's been said. You have to kind of really look at the global picture. But in certain scenarios where if there's a lesion that's in isolated growth, or if there's a lesion that could cause symptomatic issues, that's where radiosurgery is a very good option for patients. We can, these are radio-resistant tumors, but we can very focally ablate using a very high dose per fraction and get good control.
Thank you, Dr. Sachdev. Another radiation-related question, not metastases, but in someone who's had a recurrence a long time ago had radiation. So the question reads, I've had full proton radiation treatment and gamma knife for clavus chordoma, told by multiple facilities that I cannot get any more radiation. However, my proton treatment was in 2003, my gamma knife treatment was in 2007. Based on the half-life, hasn't there been enough time since having radiation for me to get more treatment? I'm being told that more radiation would cause blindness, other side effects, or worse. It's a common question when people have recurrence long after they've had their initial treatment, the local recurrence, can I park more radiation there?
It's a very good question and something that we deal with all the time. Unfortunately, there's no perfect model that tells us how, what part of the body will forgive what dose of radiation that it's seen before after what period of time. People have undertaken efforts to try to use imperfect data to come up with, certain guidelines or certain, using basically data from real patients looked at retrospectively, empirical data to guide us as to what may or may not be safe. But that is a very complicated question. Typically, in a scenario like that, without a clear-cut answer, you really sort of seek a multidisciplinary opinion. That's where you get many heads together. What we'll do normally nowadays is we'll actually be able to rebuild all of the old doses that have been delivered, just as, for example, if you were to email a picture to a friend or colleague, there are standard formats for a picture, like JPEG or GIF. A lot of what's done in radiation oncology is actually done on a standard language, independent of what machine's been used, what platform's been used, what facility delivered the treatment. We have that standard common language that can actually be transported, it can be transmitted and can be rebuilt on a scan. So we can try to rebuild what has been delivered, recreate that 3D dose distribution, try to radiobiologically calculate what organs may be able to get some more dose, although it's never a perfect conclusion. And then you kind of try to answer that question. And it's a very individualized answer for each patient, looking at the anatomy, looking at the shape and the extent of the tumor, and looking at all the doses and the time elapsed between the prior doses.
And add to that, excellent point. I've seen a lot of these cases, and it's the ones that keep me up at night. These are tough decisions and recommendations to make. When I counsel patients on this situation, and there are patients I have done retreatment after similar scenarios, and some I've said I recommend against it. It's a matter of playing the percentages. So when a normal tissue is irradiated to a certain dose, there's a reasonably precise estimate we can establish for the risk of something happening to that tissue. And then when we start to escalate the dose to that tissue, that risk escalates, and sometimes exponentially. And when that happens, we start saying, we can't go beyond this. So whenever I treat chordoma up front, in my mind, I'm playing the percentages. I'm looking at what that tissue is receiving, looking at what the tumor is receiving, trying to find the fine balance there. But in a retreatment setting, we believe there is some recovery of normal tissue from prior radiation. But the data of it is based on rhesus monkey data on spinal cords. It's not the most compelling. And so it provides us with some challenges as to ground ourselves as, is this safe to do? And so as Dr. Sachdev mentioned, it's doing a very detailed analysis of everything that's been done and what it looks like at that point. But sometimes it actually takes a responsible radiation oncologist to say, I'm sorry, I just don't think this is a good idea. Because we swear a Hippocratic oath to do no harm. And when we start playing those percentages start getting too high beyond what we think we can help, then it becomes, that becomes the basis of our recommendation. And the challenge becomes different chordoma radiation oncologists across the country may come to different conclusions. And thankfully we all know each other, so sometimes we bounce ideas off each other. But it's it's a challenging situation that is not, we don't reach that recommendation without tremendous thought.
Thank you. Dr. Park, have a question regarding the approval process with FDA to get new treatments approved, and specifically, how can we, as in patients, how can patients help? He's chuckling.
Patients could do a lot. FDA is a government institution. Josh will talk about this. So he'll discuss the entire process, how drugs are approved. Obviously, there has to be an indication that's worthwhile evidence, but you'll be surprised how much the public can influence the FDA. And I have friends at the FDA, and they tell me the same thing. Often, decisions are made based on advocacy groups. So yes, but as far as the process, Josh is going to talk about the leader.
Sure.
The entire process from the lab to the bench, from the bench to the clinic, and how it gets approved.
Sure, thanks. I'm going to do a couple more questions from my list here, and then we'll move to questions from the floor. So I'm not sure how, do you want to get people lined up perhaps while we do the last couple with a microphone? Okay, sure. All right, so what are the recommendations for patients who have not chosen surgery, only radiation for initial tumor treatment? Is post-radiation surgery an option, Dr. Wolinsky?
Well, I think that surgery is an option, but it's something that you have to keep in mind that the surgery itself is going to be much more difficult to get through. It's going to be much more difficult for recovery, and I think that the chances for a negative margin resection can be harder just because the scarring is so much more severe, especially proton. And the neurologic risk is way higher. So it's a possibility, but, you know, and I don't think that the door closes on anybody, but it's one of those things you have to balance. And sometimes, you know, you see a tumor that the patient doesn't have very much symptoms from. It involves the entire sacrum, and you're talking about doing a sacrectomy and losing all the bowel, bladder, and sexual function in a lumbopelvic reconstruction. So people don't, nobody wants that, right? And so that's the balance of, do I give radiation now and then do the surgery if the nerves become sacrificed by the tumor or the radiation or whichever caused them to get injured, but then the surgery might not be really realistically possible? Or do I accept the consequence of doing radiation alone and potentially some experimental chemotherapeutic option?
Right. Dr. Gondi.
One more thing, how critical it is for the radiation oncologist who treated that patient to speak to the surgeon who's seeing, because sometimes that area may not have gotten very high doses, and that opens up an opportunity. So that collaboration is super important.
Yeah, absolutely. And related to a recent question that you two answered, I have had 70 gray of IMRT for cervical chordoma and have a stable recurrence. Would I be a candidate for CyberKnife or alternative radiation?
I'll start and I'll pass it to Dr. Sachdev. My bias is you're always a candidate until we take a look at it. There's so many variables to it, geographically, anatomically, related to the dose, related to the percentages that we spoke about. And sometimes it's not just one modality better than the other. It's, you know, again, that toolbox idea that I had. Some situations are better than others, but it's worth looking into.
That was very well said. I don't have much to add. You basically just have to look at all the variables, the time since the last dose, where the dose was exactly. You always have to remember with radiotherapy, where it's a 3D dose cloud, so you can't really fully understand the treatment that a patient got just by the number, the gray, the dose units. You have to see where that went, where the dose fall off was. So you kind of have to. It's a very, involved process, but it's certainly, I would agree, worth an opinion. We have to go and sort of see what was treated, what can be treated further, and what's the right tool for that job.
Great, thank you. So let's take some questions from the audience. I mean, a lot of us, maybe most of us, have very complicated backstories, and so I recognize that, but let's try to keep our questions to the panel fairly pointed and concise, so that we allow everyone who has a question time to ask what they need.
Thank you. This question is for Dr. Park, primarily. For those patients who have essentially, and I'll use the word, exhausted their surgical and radiological radiation options, and I heard the presentation earlier, what are sort of the best oncological options that a patient might have, and which ones should they think about and how to pursue it?
I would strongly encourage all of those to enroll in a clinical trial. That's the only way we really understand what's effective, what's not. I know that a lot of the patients come with us because everybody wants immunotherapy, but we have no idea how effective it's going to be. Especially for disease that grows so slowly. If something is stable, we don't know what that means. And I'll give you an example. Majority of my patients have suffered from, not from chordoma, such a rare disease, glioblastoma. And everyone in immunotherapy, you see these commercials, right? Optivo commercials where you have a grandfather sitting on a hill, everybody's running around, they all look so happy, right? And patients see that and they want it, and they hear about other patients who had different cancers. We looked at it in glioblastoma. It doesn't work, unfortunately. It failed. It failed at newly diagnosed setting. We looked at the combination of nivolumab with ipilimumab or vice versa. There's no signal, unfortunately. It completely failed. That was at the NCI. The folks in Boston looked at a recurrence setting. It failed. So without knowing if something is effective and just asking for it because it's popular, rather than that, please enroll in clinical trial. That's the only way we're going to know whether agent XYZ is effective or not. Now, it's our job to make clinical trials more available and have a variety of trials that'll fit more patients, and that's, I think, what the foundation's working on.
Thank you, Dr. Park. If there's not another question, I'll just go right here.
Dr. Park, when you recommended that every other scan should be a full spinal scan, would that be for a clival patient as well, or
So,
is that?
I think I was thinking about a clinical trial setting,
Okay.
but a patient's been stable for years. I would not routinely scan the entire body. So again, it has to be customized for each particular patient.
Okay, and then a comment about pain. My wife has really significant post-surgical pain, and two things have been her salvation. Caffeine is one, and CBD is another. And I don't know if this is the panel or if this question goes to Joan, but is there much cannabis research around chordoma, or is there any that anybody knows of?
I think all the research around cannabis, there's no sound studies around it. It's legal in some state levels, but federal level it's still not. So I think that's sort of the drawback in getting good sound studies around cannabinoids, CBD, all of that.
I'm going to add something because patients ask me about cannabinoids and marijuana, medical marijuana, or off the street marijuana, whatever. And I have to say that, from a practical perspective, if you look at cannabinoids and marijuana compared to the opioids and things that we use and dispense, it's probably a much safer drug, but we don't have enough experience with it from a research perspective. And I think just talking to people out there in the chordoma world and what they've done will give you a better understanding of what actually is possible for your wife and other things as far as treating that pain. Because they figure out stuff way better than we figure it out. I mean, it's just, it's amazing, right?
So I'll add to that. I said it earlier, I learn more from my patients than I can teach them. And I've become a believer in some of the cannabinoids to help symptoms. And so patients always ask about it, and I think thankfully it's legalized in Illinois, and I've over time started directing patients to considering it. There's a lot of steps to go through, but if someone is having a significant symptom, I'm not an expert on cannabinoids, but a lot of these dispensaries, they do have experts that are affiliated with them who can advise on which strains to use specific to someone's symptoms.
Not just CBD, but CBG as well, I guess. Different cannabinoids, and like CBG is supposed to theoretically have tumor suppressant qualities, and CBDA has anti-inflammatory qualities. So it's obviously in its infancy, but hopefully more can be done.
Thank you. Somebody over here. Oh, yeah. Just ask it there, Deric.
Hi, I just have a question about like long-term, surviving long-term. It's been 18 and a half years for me, 16 and a half post treatment. Is there a point at which I don't have to get an MRI? Or is this 20 years from now, it can still reoccur? Or I'm assuming we don't know the answer, but what's been your...
I'd say we don't know the answer, and I'd say it's a personal decision about when or if you ever want to stop scanning yourself. I mean, I think that there's sort of there's two groups of people with recurrences, right? They're and these are the people with en bloc resections. There's the early group, and then there's the late group, right? And how late is late? I don't know. I mean, and I think that there is some peace of mind when you get that scan back and you know it's negative, and it's like, yeah, that's great. Let's go celebrate. It's like having another grandchild or something like that. It's good.
I'm going to add to that I agree with the uncertainty, and maybe it's just my bias, but I have seen long-term recurrences, late recurrences, but I would promote continued surveillance, maybe not as frequently, because it's challenging when it becomes symptomatic and then you notice it. Makes sense.
But it's interesting, right? We deal with this in the Chordoma community a lot. This idea that initially after you have surgery and radiation, then you have scans every 3 months, every 6 months. People make it out to 5 years, which traditionally in oncology has been sort of deemed to be the cure. You make it to 5 years, but we all know with chordoma that the longer you go, actually the higher your chance of late recurrence. So we get this all the time from patients, and what neurosurgeons and non-chordoma expert neurosurgeons will tell patients, you've made it to 5 years, you can cut back to every 1 or 2 years, when logically, based on what we know about chordoma, you should continue to monitor it. I'm not sure what the answer is. There's not many of us who've made it out to 18 years, so we have very little data around that. But this very common thing we get from patients in the community is, 5 years now, every year or every 2 years, and people take it almost as a sign of, awesome, I'm out of the woods, when really that's when you really should be paying attention. It's a big problem.
Yeah, I couldn't agree more. And also, because it's such a slow-growing disease, the chances are that the scan will pick it up before you have symptoms, like Dr. Gondi mentioned. So I would advocate for scanning.
For Dr. Wolinsky, are you using 3D printed imaging of tumor at this point?
The question was, am I using 3D printed images of tumors to plan my surgeries? So I've played around with it. I have a lab that has 3D printers in it. I find it's actually more useful for educating other people about the tumor and where it is, mostly because I now have a three-dimensional kind of view of what is in my mind's eye about what the tumor looks like. So I'll sit and pan through images for a long time and kind of reconstruct it in my head. I do like 3D reconstructions on the computer screen and turn them around that way. I think the 3D printing has a bigger role in designing custom implants for patients. So if you think about sacral reconstructions, I think they're very difficult reconstructions to have patients undergo, but they're more difficult to actually have heal. And so improving the way we make custom implants for patients so that it can encourage bone growth minimize how proud some of these screws are so that patients don't feel any of these things, I think that's probably more useful than 3D printed models to understand where the tumor is. I don't think it's not a bad adjunct though.
There was one question on this list that I wanted to get to, which is about something we haven't heard much about, is modulated electrohyperthermia, a type of ablative therapy, and how do this treatment and ablative therapies look as options for chordoma? Who wants to take that one? Oh, there.
This falls into the radiation oncology sphere because it was about 2 decades ago, a decade and a half ago, when we were looking at hyperthermia as a local therapy modality, and it came through in the radiation realm. I admit I've never used it, and there's not a lot of literature for its use in chordoma. The general principle is it's fairly comparable to any ablative treatment in being very localized. There's a certain degree that heat can travel in a particular structure. And so the general principle is, while it is very useful as an ablative opportunity within a localized area, as we talked about earlier, chordomas, especially up front, are not typically just localized. And so I think there's room to look at that, but since hyperthermia had a lot of vogue about a decade and a half ago, our radiosurgical capabilities have significantly expanded. So I think it's most radiation oncologists biased to do, if we were going to do a localized treatment, to rely on radiosurgery since it has much more evidence to support it.
So can I add to that too? Similarly, but on a slightly different direction, there is something called laser interstitial therapy that neurosurgeons have now been using for, I don't know, maybe 5 or 6 years in the brain for lesioning metastatic disease or other tissues. And so what it essentially is it's a laser fiber that gets placed into the brain, into the tumor, and then laser is delivered through that fiber. And during an MRI scan, we watch how much heat that fiber is creating around that area to try to treat that tumor. Now, there's one of our neurosurgery colleagues down in Houston at MD Anderson, Claudio Satsui, who has started using it for metastatic disease in the spine, and also has started using it for recurrent chordoma in the sacral and spinal regions. I don't think he's used it at all for clival chordoma, but it is, I think, a promising adjunct. And so I would say for recurrent tumor, I put surgery, this interstitial therapy, and radiation therapy all into the same sort of category where you're locally trying to treat that tumor. You're not trying to systemically trying to treat that tumor like with chemotherapies. But it is an adjunct as another thing in our toolbox to try to treat this. It has its limitations right now. So in the brain, we can do this fairly well with what we call stereotaxis, which is like a GPS of the brain, of sticking this thing in the right place. And we're doing this in the MRI suite, so if somebody has an intraoperative MRI scanner, it's easier to do it in that suite because we have to watch how the heat is produced by this laser so it doesn't damage things. In the spine and the sacrum, it's a little bit more difficult because we don't have intraoperative MRI scanners that are great for that. One of the things that I worked on in my lab was building robots out of plastic to deliver these. So we have a prototype for something like that. So down the line, I think this is something that we can use on a more reliable basis. But right now, Claudia is the person who's sort of pioneering this. I think is doing a great job with it.
Thank you. Go ahead.
So we may be able to answer this question. Perhaps Josh could talk about this later. There's another modality called focused ultrasound. My understanding is that group has approached the Chordoma Foundation, potentially running a clinical trial.
Which group?
Sound Foundation.
With the idea
to...
to...
For cranial clival chordoma, I would assume then spinal or sacral, but potentially for this.
I'll mention one thing about laser thermal ablation that does have a role in chordomas, and that is the situation of cerebral injury from radiation that can happen. So most commonly it's the temporal lobes right next to the carotids if it does happen. And that's actually where there's clear evidence that laser thermal ablation does help in a situation like that, is to be able to essentially stick a needle in and burn that area, prevents patients from developing continued cerebral injury and potential symptoms from that.
Don't you have the same issue though with respect to like the heat spill over to the neighboring areas?
In a situation of cerebral injury, when it's caught early, it's a fairly small area, and typically so laser thermal ablation typically covers up to 3 to 4 centimeters in its area, but it usually will be sufficient to burn off the area where there's injury to prevent that injury from continuing to grow to a larger area.
Sure. Any more questions from the?
Doctors, I'd like to thank you for helping with the research and continued push towards our goal of trying to get proper treatments for the chordoma. One of the things I think you mentioned earlier was a tumor was damaged by radiation, and after it was damaged, it was unable to grow. And I had read some information on the hyperthermia that we were talking about a few minutes ago, and it seems like Germany, I believe, has a pretty significant program along those lines. Would you think about developing a similar program here in the United States? Because the hyperthermia, I guess, like you were mentioning with the radiation, if we could damage the tumors, then, that would stop them from growing okay on a large scale. I don't know that much about the science, but I just seem to read a little bit here and there, and it seems like it's all kind of connecting as far as these heat treatments or radiation damage to the tumors, definitely seems to have an effect on, their growth patterns.
We do have historically a lot of experience with hyperthermia with radiation at Northwestern. Our institution has published data looking at outcomes of synergistically using both fractionated radiotherapy and hyperthermia. But as Dr. Gondi mentioned, a lot of that has been, for very recurrent superficial lesions. So we have a very large outcome series of patients with recurrent superficial metastatic breast cancer, where it's easier to very focally and kind of scientifically, objectively deliver the heat all the way to the depth of the tumor tissue. A lot of the studies that have looked at combining hyperthermia with radiotherapy have been done in the context of gentle fractionated radiotherapy. So if you recall the curve that I showed in my presentation, it's basically trying to increase the sensitivity of the tumor cells to radiation. And for multiple reasons, I'd say, I'm not fully familiar with the work that Dr. Wolinsky mentioned at MD Anderson, but sort of outside of the confines of that, it'd be harder to very focally and objectively deliver heat deeper into the tissue. And the other aspect of what's happened in the radiation oncology realm, with the advancement of modern image guidance, with the ability with proton beam particle therapy to give a very high dose, oftentimes one could argue, well, maybe you don't need that extra sensitization with heat. And especially with radiosurgery, you're giving such a large dose per fraction with such precision and accuracy that, hyperthermia in that context is probably less appealing and certainly, to my knowledge, hasn't been very well studied. That I'm aware of in combining hyperthermia with radiotherapy has all been done with sort of local, heat applicators. And yes, that's one of the proposed mechanisms of increasing the sensitivity of the tumors to radiation, one of which is, better vascular flow, better oxygenation of the tumors, a better chance for tumor cell apoptosis or cell death, better radiosensitization to more resistant parts of the cell cycle. And so that's one of a few proposed mechanisms.
Thank you.
Thank you. I have one question specifically regarding carbon ion therapy, how it relates to proton beam therapy, whether it's worth pursuing that as an option if it shows advantage.
So was told to keep my talk to 15 minutes, so I took the carbon stuff off. No, so I think it's an opportunity. It really is an opportunity that we need to continue to explore. So in the United States, we don't have a carbon ion facility. Many places are trying to put one in. It's at least 2 to 3 times the cost of a proton therapy facility, so it becomes very challenging. And the problem is when you put in that kind of cost and you treat, and the only thing that it really treats is rare tumors, it becomes, you start to wonder the relative economic model of being able to maintain that. There are carbon ion facilities that are in Japan and in Europe, and there are some very good experts who are taking care of patients out there. So the way carbon ion works is it's a large particle. It's a heavier particle than protons. So it has the same benefits that protons has when I sort of outlined that in terms of its properties. But on top of that, the carbon itself is heavier. So the thought is that when it deposits in the tumor, it's exacting more DNA damage. And in fact, beyond just DNA damage, because it's so heavy, it's just rapidly killing tumor cells right there and then. That's the principle of carbon ion. The challenge of carbon ion is that heavy particle can as much inflict damage on normal tissues as well. And so that becomes sort of this challenge of how do we shape it, how do we do it properly. I didn't mention it in my presentation, but that meta-analysis that I showed you, and it's just very limited carbon series in there, that's very limited data with carbon therapy, but I found it interesting, but I'm not believing it yet, that the series that were treated with proton therapy had better survival than those who were treated with a carbon. I have no biologic plausibility to explain that. But I think it's an area of continued research, and if available for patients, I would certainly encourage them to look into it, because the principle of it as it relates to radiobiology of chordomas and radiation therapy seems to make sense to me.
Thank you. One more question on medical therapy. Oh, sorry. Yep. Just get the microphone first, if you don't mind. Thanks.
If the spine is deteriorating because of the radiosurgery, what are different options for reconstructive surgery at that point?
So I didn't hear the last bit. What was it? If the spine is deteriorating as a result of the radiosurgery.
Correct. What are the options, if there are any options, for reconstructing that spine?
Has that spine been operated on already?
There's been rods put in, correct?
Right. So, so it's a complicated. Whoa. I'd have to reconstruct my spine. It's a little bit complicated and unique for each person. So it depends what part of the spine's been operated on and what has been done the first time and what are your options. And let me go through what I mean by that. So when we reconstruct the spine, if it's the sacrum, we're putting screws and rods in there to hold things together. Okay, and then we also put bone graft in there to ideally allow bone to grow through that area. Without radiation therapy, what happens is that there's a lot of stress on all these junctions, okay? And there's stress at where the bone and the screw interface, and there's stress at where the rods and the screws interface, okay? Think of these rods and screws kind of like a very fancy, very expensive erector set that you might have played with when you were a kid, okay? And think of the bone as like when you're hanging up a painting in your house, that if you get that screw into that stud, it's going to be great. If you get into sheetrock or soft osteopenic bone, osteoporotic bone, then it's going to wiggle out of there. So over time, what happens is that there's a lot of stress on these different places. And my hope is that everything heals, but if it doesn't, my second hope is that if you have a problem, it's the rod fracturing rather than the bone-screw interface, because it's a much easier problem to fix, because you can change the rods out. And usually if somebody's out of surgery at least 1 or 2 years, and it's the rod that breaks, that screw-bone interface is actually very nice and strong. And so then you can maybe go to a stiffer rod or more rods or something like that, because if you make the construct too stiff to avoid the rod breaking in the first place, you might pull out the screws and create a different problem, because in the sacrum, once you start losing your fixation points, there's nowhere to go. If you add radiation to that milieu, essentially you're softening up the bone. The good thing about the radiation is that it's not like conventional radiation where we're radiating your whole body. I mean, we're radiating that area where the tumor was and maybe a little bit beyond that. So if it's in the mobile spine where the problem is, there are good points of fixation above and below where you were operated on before. The downside is that your construct now grows bigger and your body becomes much more stiff. It doesn't mean it can't be done. It just means these are just different consequences that we deal with. So if you think of patients that don't have tumors, like our patients with scoliosis that have operations, they can have very long screw rod constructs and be very stiff, but they can be very functional in their life. Does that answer the question?
Is there some kind of a, I say JV well, but
yeah.
bone structure that they can put in there to strengthen?
So there is stuff that we use, bone cement or methyl methacrylate, which is a very old substance. It's kind of what your Corian countertops are made out of. And we make it, it starts off as a liquid and it solidifies. And so if you have a bone that needs a screw, we can put that in there, kind of like a molly bolt, and then put a bigger screw in that area to try to get things to hold. It's not as good as what our native thing is, but it's an option for that. As far as other JB Weld concepts, there's something called bone morphogenic protein, or BMP2. The commercial name is Infuse. It's by Medtronic. Now, this is something that I don't promote because, and it's something I don't use in tumor because there's a contraindication to it because we don't know what it does for tumor. It creates bone growth, but it might also create tumor growth. And so that Medtronic, you know, when they did their FDA stuff, that there's a warning on there not to do it in oncology. Now, one of the early pioneers in spinal oncology is a guy named Sunny Sundaresan from New York. Exceptionally eccentric, exceptionally brilliant. And one of the things he wanted to do when this was becoming commercially available was to do a trial in tumor patients with using this product, because there's a thought actually that this might actually be inhibitory to tumor, but nobody knows. The company wasn't willing to take the risk and nobody is willing to fund it, and they actually said you can't even use our product in the study. So he never got to do that study, and so nobody uses that, okay? There's another drug out there, and there's newer versions of this, even though this is a fairly new drug, is Forteo, which is a parathyroid hormone analog, which is used for osteoporosis to try to build up bone. So when we think of osteoporosis, most of us that get it, we're losing bone density. And people are placed on things called bisphosphonates like Fosamax. Essentially what that's doing is stopping you from losing bone, but it doesn't gain bone. But Forteo, being a parathyroid hormone analog, actually is the only drug out there that can, well, now there's newer versions, so I shouldn't say only drug, but it's a drug that actually allows you to build up bone again. So if you're an osteoporotic person, you could maybe become a non-osteoporotic person. Again, there's concerns in tumor whether or not that could be bad for tumors. Nobody knows the answer to that, but that is a possibility if you're developing fractures from radiation or something like that to think about. Does that answer it?
Yes. Thank you. Maybe one last question before we break for lunch. There's a question regarding specifically an EGFR inhibitor, gefitinib, and whether or not there's been any good results with that for treatment of chordoma.
So EGFR is a compelling target for chordoma. So what EGFR is stands for epidermal growth receptor. So you can think of insulin. On the cell surface, there's a receptor that instructs cells whether to take in sugar or not, and it's very similar to that. So there are different ways to target EGFR. The gefitinib is a type of what we call small molecule inhibitor. It's tiny, gets into the receptor signaling. It prevents this receptor from signaling. There's also an antibody, cetuximab, which binds on the outer surface. Now, unfortunately, gefitinib, some people looked at it, it failed in chordomas, but there's a newer generation of EGFR inhibitor that study called afatinib. It's much more potent, more specific. That study is ongoing in Europe right now. And talking to our colleagues, it seems promising, but yet we don't have the full results. But hopefully we'll know soon. So yes, that is one of the targets that we're very interested in chordomas.
So just a personal note, so afatinib is the drug that I'm taking, and have been taking for 14 months, and has shrunk my residual tumor.
Are you taking it as a trial or as compassionate use?
Compassionate use.
Compassionate use.
I had to lobby my own jurisdiction to get it covered. It was in Alberta, it's $5,000 or $6,000 a month.
So I was working with Dr. Leach, who is a very well-known chordoma expert. We were trying to get this patient afatinib exactly for that reason. It's a long story, but short of it is a woman from China with intractable chordoma came to Boston to get proton, and Dr. Leach was kind enough to actually let her stay with him, and the tumor was growing. We were trying to get afatinib through a company. Unfortunately, she progressed. But yeah. Before that,
jury's out. Okay, join me in thanking our illustrious panel for donating their time.